Okay.
Hi. Hi. Yeah, we can.
Good evening, boss.
Yeah. Yeah, hi.
Good evening, Darshan.
Good evening, Rajat. I think everyone has joined now.
Yeah.
Yeah.
I
It's
saw
about
I saw Amrish Krishna in the waiting room, so I think you can promote.
okay.
Not able to find him in the attendees.
I did find him, but promoted him as the panelist.
Is there? Is there? So he just needs to join in as a panelist.
Yeah, I've done that.
Yeah.
Can we start, sir? I think it's 8:05.
Yeah. Okay. Good evening, all. I think. Yeah, I welcome all for the April session of the Journal Club. This month, we are talking about membranous nephropathy. Of all the talks I've heard about IgA nephropathy in World Congress of Nephrology, I just thought there is no other disease in nephrology other than IgA nephropathy currently. So I thought it's a good change to talk something about MGN. I invite Paramita to go through about the multi-target therapy. And I mean, we have already heard about multi-target therapy in lupus nephritis. So it's let's hear about the multi-target therapy, its effectiveness, and how did it fare compared to the conventional Ponticelli regimen? Paramita?
Yes.
Yes, sir. Yeah.
Yes, sir. Good evening, sir.
Good evening.
Sir, should I start?
Yeah, you can start.
Good evening, respected faculties, seniors, and my colleagues. So we'll be beginning today's monthly ISN Journal Club discussion with this following article. So it is a multi-target therapy with a corticosteroid, cyclosporine, and mycophenolate mofetil for idiopathic membranous nephropathy, a prospective randomized control trial which was published in the Journal of Nephrology, Dialysis, and Transplant in 2024. So a bit of background about this disease. So it is the most common non-diabetic cause of nephrotic syndrome in the elderly, except in the African American population. It accounts for 20 to 40% of all renal biopsies, and the incidence gradually increases with age, touching almost 50 to 60% in adults aged more than 65 years. So it is basically a pathologically defined condition where there is subepithelial deposition of immune complexes which incites damage to the glomerular basement membrane and podocyte, leading to subsequent protein loss in the urine and nephrotic syndrome. So it classically follows the rule of 30, like we know from as per the natural history of the disease, that is 30% patients go into spontaneous remission, 30% ultimately progress to end-stage renal disease over the course of 10 years, and 30% patients have gradually worsening proteinuria requiring the usage of immunosuppression. Now, membranous nephropathy is classically classified as primary and secondary. The primary variety means basically which is associated with the autoantibodies. It accounts for almost 70 to 80% of the cases. And secondary causes where it is associated with certain underlying malignancies or autoimmune disorders, or maybe drug associated, or even infection related. Now, the discovery of the PLA2R antibody in 2009 revolutionized the classification and the pathogenesis of this disease. Gradually, with the emergence of more autoantigens like the NEL and exhaustocin, it is now recommended that even if we have presence of autoantibodies, secondary causes should always be excluded in any patient with membranous nephropathy. So the current treatment guidelines as proposed by KDIGO 2021, patients are first classified according to their risk stratification. So low risk patients are those who have a normal GFR with proteinuria less than 3.5 gram, or they had a nephrotic range proteinuria with more than 50% reduction with 6 months of consecutive therapy. Then only wait and watch policy is to be followed and no active immunosuppression is needed. For patients with moderate risk, as defined by normal GFR and proteinuria more than 3.5 gram, which has not decreased by more than 50% with 6 months of non-immunosuppressive therapy, and patients who have not fulfilled the high-risk criteria, then immunosuppression can be tried, so which can either be rituximab or a combination of calcineurin inhibitors with glucocorticoids. These same set of patients, if they have not had a decrease of more than 50% proteinuria within 6 months of therapy, plus they have some of the high risk features like serum albumin less than 2.5 or PLA2R quantitative levels more than 50, or urinary alpha-1 macroglobulin or IgG1 and beta-2 macroglobulin more than the mentioned cutoffs, should go for definite immunosuppressive therapy. Or if the patient has a GFR of less than 60 and has a proteinuria which is more than 8 gram per gram for almost 6 months, then even cyclophosphamide and glucocorticoids can be tried as a first-line regimen or rituximab with CNIs. And the last category, which is very high risk, that is patients with complications of nephrotic syndrome or a rapid deterioration in renal function, they are to be definitely treated with a combination of steroids and cyclophosphamide. So basically the group of drugs or the regimens which are used in membranous nephropathy, the most conventional and the oldest regimens being tried were steroids and cyclophosphamide. The mechanism of action being targeting both B cell and T cell inhibitory action, and they have the longest data on both the disease remission, the 10-year renal survival, as well as the efficacy on the data on safety is adequately available. Also, for this disease, calcineurin inhibitors had been tried. So calcineurin inhibitors, like we know, they inhibit the cellular phosphatase calcineurin, thereby inhibiting subsequent T cell activation by inhibiting the cytokines responsible for T cell activation like interleukin 2, interleukin 4, and gamma interferon. Additionally, they also have a podocyte stabilizing action by stabilizing the structure of synaptocodin. So they were also tried. The success rate was also good, averaging around 70 to 75% with both cyclosporine and tacrolimus, slightly higher with tacrolimus compared to cyclosporine. But the main problem with their use has been a high relapse rate of almost 40 to 50% upon discontinuation. And also, like we know, that these cause dose-related and duration-related nephrotoxicity on prolonged use or use above the recommended target doses. Next comes mycophenolate mofetil, which has been tried in various autoimmune diseases, also in transplant. They target basically inhibition of both T cell and B cell proliferation by inhibiting the de novo pathway of purine and pyrimidine synthesis. But MMF has not been widely tried in membranous nephropathy. There are a few small observational studies and one pilot study which combined MMF as an add-on therapy with CNIs and steroids. Last but not the least, rituximab, which has a persistent sustained B cell depleting action by depleting both the pro B cells and the mature B cells. The advantage with rituximab was a relatively safer adverse effect profile compared to our usual steroid, cyclophosphamide, or CNIs. So here comes the role of this multi-target therapy, where we can combine all the three like steroids, CNIs, and MMF. Previously, we have the data from diseases like lupus and obviously in transplant patients where the combination has been tried. So a brief history about the evidence which exists regarding the use of CNIs in membranous nephropathy. The first trial which had tried using cyclosporine was a small study done by Catron et al. In 2001. Only cyclosporine with glucocorticoid was tried with low-dose glucocorticoid. They did have a good response rate of 75%, but was complicated by almost 60% relapse rate at the end of 30 months of therapy. Following this, in 2007, Praga et al. Tried supportive therapy with tacrolimus in patients with membranous nephropathy. Both trials had around 50 patients. So this again had a good response of 76%, but again was followed by a relapse rate of almost 47% at the end of 30 months of therapy. We have the trial from India done by Raja sir et al. Reported from PGI, which had explored tacrolimus plus glucocorticoids versus our conventional modified Ponticelli regimen. The response rates were comparable at 12 months of therapy of 71 and 77%. However, when the long-term data was analyzed at around 18 months, only 59% of the patients continued to be in remission. Those who were previously treated with tacrolimus and glucocorticoids. So around 40% patients ended up having a relapse compared to only 6.7% in the conventional group. And lastly, the latest trial, Mentor, which came out in 2019. It tried cyclosporine with rituximab. Again, showed a very poor response of cyclosporine at 24 months compared with around 60% remission rate with rituximab, also mirroring the high relapse rates as seen in the previous trials. So hence, no randomized control trial till date has been tried as a multi-target therapy in membranous nephropathy. Also, what is to be seen is that by using combination therapy, if you can reduce the doses of the individual drugs and thereby avoid not only the adverse effects associated with CNI use, but also by targeting a multimodality approach, if we can reduce the relapse rates associated with isolated CNI use. So the aim of this study, it was to compare the efficacy and safety of multi-target therapy with cyclical alternative therapy in idiopathic membranous nephropathy patients. The outcomes were defined as there was a single primary outcome, which was the composite of complete or partial remission at 12 months. And for the secondary remission, they wanted to study the complete remission achieved at 12 months and also the adverse effect profile in both the treatment arms at the end of 12 months. The definitions used in this trial: complete remission was defined as reduction of proteinuria to less than 300 milligram in a 24-hour urine protein sample. Partial remission was defined as a reduction of proteinuria by more than 50% of the baseline and reaching less than 3.5 gram. No response was defined as a reduction in proteinuria which was less than 50% of the baseline value. PLA2R levels were quantitatively examined by ELISA and the usual cutoff of more than 20 RU per ml was taken to be positive. So the study design, it was a single center study carried out at the Beijing Friendship Hospital. It was a randomized control trial. Only the primary investigator, the only one investigator who was in charge of assigning the treatment was blinded. Other than that, the participants, investigator or the analyzers of the trial were non-blinded. It was an active control trial, tried cyclosporine with the usual conventional cyclical steroid and cyclophosphamide. And enrollment was carried on for 2 years between June 2020 and January 2022. The funding was done by the Beijing Municipal Administration as well as the concerned hospital, the Research Foundation of the Beijing Friendship Hospital. The inclusion criteria: patients who had biopsy-proven membranous nephropathy, which was studied by all three modalities, that is light microscopy, immunofluorescence, and electron microscopy. The results were validated by 2 separate renal pathologists. Age had to be between 18 to 70 years with an estimated GFR as per the CKD-EPI formula of more than equal to 60 ml per minute, a serum albumin of less than 3 gram per DL, and nephrotic range proteinuria, which was more than 3.5 gram and had not decreased by more than 50% during an observation period of 3 months before randomization. Exclusion criteria were secondary causes, pregnancy or breastfeeding, uncontrolled active infections, previously being treated with an immunosuppression 3 months prior to screening, or the use of any biologicals 6 months prior to screening, or those who had previously been treated with any form of immunosuppression and had not subsequently responded. These patients were to be excluded. Now, randomization was done in a 1:1 ratio by a computer-generated random number table. Allocation concealment was done using sealed envelopes. All patients had to undergo a screening period of 3 months prior to randomization. During this period, they received the standard care of either ACE inhibitors or ARBs at the maximum tolerated dose and or targeting a blood pressure of less than 130 by 80 millimeter mercury. After randomization, these drugs were continued as a part of standard of care in patients in both the groups. So what was the intervention? In the multi-target therapy, oral prednisolone was started at 1 milligram per kg per day. The maximum dose was 60 mg, which had to be maintained for 2 weeks. Following this, it was tapered by 5 milligram every week till a dose of 30 milligram was reached. This was then maintained for 1 month. After that, tapering was again done by 5 milligram every month till 20 mg was reached, which was maintained for 2 further months. And then tapering was done by 2.5 milligram every 2 months till a dose of 5 mg was reached. This maintenance dose was given for a period of 4 months. So bringing the total duration to around 20 to 22 months of steroids. For the CNI, cyclosporine was used. It was started at a dose of 100 milligram per day. Now dose adjustment was done either based on the efficacy or a target trough level which was targeted at around 80 to 120 nanogram per ml. After complete remission was achieved, that same dose was maintained for 2 weeks. Then tapering was done at 3 monthly intervals by 25 milligram till a dose of 50 milligram was reached. This 50 mg dose was maintained for 12 months, followed by stepping down to 25 mg, which was given for another 12 months. And if the patient had not attained partial remission, then the target dose was maintained for 12 months, and then the same tapering schedule as before was followed. In case of no response at all, the starting dose was maintained for a duration of 6 months. If the proteinuria had still not reduced by more than 25%, then the regimen was changed. And if there was a decrease in proteinuria by more than 25%, this target dose was maintained for 6 months, followed by the tapering as defined before. Finally, mycophenolate was started at a dose of 1000 milligram per day given for 6 months, then tapered down to 750 milligram for 12 months, and finally another 500 milligram given for 12 months. If we see the comparator arm, it is the usual the modified Ponticelli regimen, steroid in month 1, 3, and 5. However, methylprednisolone was given at a dose of 500 milligram on days 1, 2, and 3, followed by oral prednisolone at 0.5 milligram per kg per day for the remaining 27 days. And cyclophosphamide was given by oral route in months 2, 4, and 6 with a dose of 1 to 2 milligram per kg per day for 30 days. The maximum dose was 100 milligram per day. Statistical analysis for the sample size estimation, they assumed a estimate effect of 78.3% in the steroid and cyclophosphamide group and effect size of 85% in the CNI group. So for a statistical power of 80% and at a confidence interval of 95%, the target sample size was calculated as 78. So primary outcome analysis was done using intention to treat analysis and also per protocol analysis with estimation of the relative risk between the two groups with a 95% confidence interval using Fisher's test. For the secondary outcome, hazard ratio calculation was also done for the complete remission at 12 months. Categorical variables were analyzed using Fisher's test. Continuous variables were analyzed with unpaired students test or Mann-Whitney test as applicable. And longitudinal data from randomization to 12 months was analyzed using the generalized estimating equation. Time to event analysis, that is time to relapse of nephrotic range proteinuria, was done using the log rank test. And patients who dropped out of the study without reaching the primary outcome, these patients were censored in the analysis. So this is the consort diagram for the trial. So eligible patients who underwent randomization was 78, 39 of them to the multi-target group and 39 randomized to the Ponticelli group. Among the 39 patients in the active treatment arm, 8 discontinued intervention, 3 because of adverse effects and 5 were lost to follow-up. But by intention to treat, 39 were analyzed, and in the comparator arm, 1 discontinued due to adverse events. There were 2 losses to follow up. So 36 patients received the treatment and 39 were analyzed as per ITP. Moving on to the results, this table basically shows the baseline characteristics which were comparable in both the groups. So the mean age was around 52 years. Males comprised on an average 69 to 70% of the population. The median proteinuria was 5.6 gram across both the groups, the range being 4.7 to 7. The serum albumin was comparable at 2.1 to 2.2 gram per deciliter in all the 3 groups. 80% patients were positive for serum PLA2R in both the groups. The median level was higher in the multi-target group, but the difference between the 2 groups was not statistically significant. Baseline levels for LDL and use of ACE inhibitors ARBs and prior use of immunosuppression use was also comparable between both the groups. The results for the primary outcome. So we see here basically that there was comparable rate of complete remission or partial remission in both the 2 groups. At 6 months, 72% patients in the multi-target therapy and 77% patients in the steroid cyclophosphamide arm had achieved a composite of complete and partial remission, whereas at 12 months this was maintained at 79% versus 87%. Even in the per protocol analysis, there was no as such statistical difference between the 2 groups in attaining a composite of complete or partial remission. For the data at 12 months, for the secondary outcome, that is only complete remission at 12 months, this was achieved in 41% in the multi-target group and 36% in the steroid cyclophosphamide group. These figures show the cumulative incidence. The figure on the left, on the x-axis, we see the time, and on the y-axis, we see the cumulative incidence of a composite of complete and partial remission. which was comparable in both the groups. And the figure on the right shows only the time versus the complete remission achieved at 12 months. So again, even for the complete remission, there was no significant difference between both these groups as analyzed by the log rank test. This figure compares the urinary protein on the y-axis and with time as depicted on the x-axis, and also the serum PLA2R levels. So the solid line represents the trends of the 24-hour urine protein over time from the start of the trial to the end of 12 months. The blue line being depicted by the steroid cyclophosphamide group, and the orange line is the multi-target group. So there was a gradual decline in 24-hour urine protein level, almost comparable between both the arms. The serum PLA2R findings mirrored the decrease in proteinuria findings, gradual fall, and being comparable in both the treatment arms. Also, there was no significant difference in the serum creatinine values or the serum albumin values between both the multi-target and the treatment arms. The figure on the right shows the serum albumin trends with the time in the multi-target and the cyclophosphamide group. So we can see gradually starting with 2.2 gram per day, it has increased to 3.7 normalization of serum albumin level in both the groups. And on the right side, we see that they start with a serum creatinine of, these values are given in micromole per liter. So this comes to around 0.7 to 0.8 milligram per deciliter. They started off with that, and there was no significant worsening in either the CNI group or the steroid cyclophosphamide group over this 12-month period. Now, comparing the rates of remission, the clinical versus the immunological remission, there was a numerical difference between the patients who achieved a clinical response as compared to the immunological response. Like at 6 months, 63% patients had achieved clinical remission compared to 83% patients in the steroid cyclophosphamide group. However, as we can see here, the difference was not statistically significant. The patients achieving clinical remission gradually increased at 12-month period, 81% in the multi-target group versus 86% in the steroid cyclophosphamide group. And again, there was no difference between the two arms. Finally, moving on to the adverse effects. There was a significant difference between the incidence of adverse effects in the multi-target versus the steroid cyclophosphamide group. Only 46% adverse events were reported in the multi-target group versus 74% in the steroid cyclophosphamide group. However, what is to be seen here that the incidence of serious adverse effects did not differ between the two groups. So as far as the adverse effects were concerned, as expected, infections were the most common adverse event noted in both the groups. More in number in the steroid cyclophosphamide group, and among these infections, upper respiratory tract infections accounted for the majority of the cases. Hyperglycemia was noted to be more in the steroid cyclophosphamide group, and this difference was statistically significant. Acute kidney injury, though numerically reported more in the multi-target group, was not statistically different from that in the steroid cyclophosphamide group. And also cytopenia, in terms of leukopenia, was more common in the steroid cyclophosphamide group. However, again, it was not statistically significant. The other adverse effects was more or less comparable between both the treatment groups. Now that we've moved on to the results, a brief discussion. So the multi-target therapy was comparable to conventional therapy in the composite of complete and partial remission at 12 months. And also patients who had achieved complete remission was also comparable. Numerically, more patients with PLA2R positivity in the steroid cyclophosphamide group attained remission, but it was not very different from that in the at 12-month period. Now, previously, there has been only one pilot study with a sample size of just 21, which had used mycophenolate as an add-on therapy in patients who were initially not responding to steroid and tacrolimus. So, in this study, they waited for a period of 3 months, and if the patients had still not achieved a proteinuria reduction of less than 1 gram, then MMF was used. So, they had shown that out of these 21 patients, 9 patients ultimately required addition of mycophenolate mofetil. And after addition, among 9, 5 of those patients ended up achieving remission. So this was the only prior evidence for a multi-target therapy before this trial had been conducted. Also, the current RCT had a lower dose of cyclosporine. So the average, the mean level of cyclosporine which was used during the first 6 months in this study was 1.6 plus minus 0.3. And the trough levels were also lower as compared to a previous trial which had used cyclosporine. So the mean trough levels were, though the target was set at 75 to 125, they ended up achieving a mean level of only 68.8 nanogram per ml. So maybe this combination with MMF allowed a lower dose of CNI use, thereby helping to achieve both a good response and avoiding the long-term cumulative toxicity as usually seen with CNIs. Adverse events, like we discussed, were significantly lower with the multi-target group. However, serious adverse events were not much different, and hyperglycemia and cytopenias were noted more with the steroid cyclophosphamide group. So this is the visual abstract associated with this trial, showing a 79% response in the multi-target group versus 87%, showing no statistical significance in the remission at 12 months. So the strength of the trial, definitely it was the first RCT demonstrating the use of multi-target therapy, the first randomized controlled trial, showing a result that it was at least non-inferior to the conventional steroid and cyclophosphamide group, and it also used a lower dose of cyclosporine. However, the duration is, till now we know the results of only 12 months, and it was a single center study, so very homogeneous population that was studied. And power was done, calculation was done at 80%, so maybe it was not adequately powered enough, well enough. A brief critical appraisal. Like we'll analyze it in 4 parts. So section A, whether it was adequately designed. So the study had a clearly focused question, focusing on the target population and outcome measured and the time. So assignment, the patients were randomized according to a computer generated random numbers sequence, and all participants who entered the study were accounted for at its conclusion. Whether it was methodologically sound, blinding was not done. However, the person who was assigning the treatments was blinded, and both the groups was similar at the start of the therapy. The baseline characteristics were comparable, and apart from the experimental intervention, the rest of the standard of care was comparable between the two groups. As far as the results were concerned, yes, they were comprehensively analyzed, outcomes were measured, the results were reported for each outcome that they had initially hypothesized, and also precision in terms of confidence intervals was mentioned. However, adverse events, though they were reported, the serious adverse events, the nature of the serious adverse events were not mentioned, and definitely cost benefit analysis was not done. Whether these results can be applied locally to our population, we definitely need further studies involving a multi-center approach to see whether all populations are included, people of different ethnicities as well, and whether we will be able to apply it successfully in terms of both the cost issue and whether they can be used in our population. Definitely further studies are needed for the same. Thank you.
Thank you, Paramita. Now I invite Dr. Raja and Dr. Amresh first to comment on the presentation and then to comment on the study design and what more could be added to the study. And there are some interesting questions in the chat box. Probably we'll address after the comments from the panelists.
Thank you, Darshan. Dr. Amresh, you want to start or can I?
Yeah, Dr. Raja, if you allow, I could start, or else you can also start.
So, go ahead, please.
Okay, so this is definitely a new approach to the treatment of idiopathic membranous glomerulopathy, and it is backed by sound pathophysiological basis, because in this targeted therapy, we are targeting both B cells and T cells, which are responsible for immune dysfunction and the pathogenesis of membranous GM. But however, this study should be taken with a pinch of salt. There are certain points I would like to address. First is that further studies are required to evaluate the role of multi-targeted therapy, especially in various risk groups, such as can we use this in high risk and very high risk. And again, this study has shown that multi-targeted therapy is not inferior to the cyclophosphamide prednisolone cyclic therapy and has fewer adverse effects. But when we analyze the adverse effect, most of the adverse effects, the statistical difference is because of hyperglycemia, which is occurring probably secondary to use of methylprednisolone. And how significant will this be this hyperglycemia, which is most likely for a short duration, what will be its impact on the clinical outcome? Then also we have the tapering of steroids was quite unconventional, and further studies are also required to define the tapering of steroid as well as cyclosporine. And the presenter has presented the study very well. I congratulate you, Dr. Promita, for this presentation, and over to Dr. Raja Ramchandran.
Thank you, Amrish, and I congratulate Dr. Promita for the very nice presentation. You did very well in your presentation part, which is largely restricted to the article presentation, but I think the critical appraisal could be a little better. So, if the chairman present permit, I think I have a 2-minute comment. Can I go ahead? Dr.
Yes, sir, sure.
Thank you. So, one is the general comment on management of membranous nephropathy, and then with respect to this clinical trial. See, among all the primary glomerular disease that we have, membranous nephropathy stands out as the only one where we have a reasonable understanding of the pathophysiology of the disease, and we have well-structured clinical trials which inform clinical decisions. Without going into the specifics, I think cyclophosphamide and corticosteroids and rituximab are the first-line therapies. Rituximab, pertinent to this study as well, rituximab represents a newer approach for the management of membranous nephropathy, as it offers a purely steroid-free regimen, but for the pre-medication part, which is a paradigm shift in the management of membranous nephropathy. Yeah, with respect to the corticosteroids and cyclophosphamide, significant dose of corticosteroids required in the cyclical therapy, poses a substantial obstacle for, routine use, especially when rituximab is available, and can actually intimidate a clinician, posing with doses over 10 grams of methylprednisolone equivalent. So among all the kidney disease, modified Monticelli offers the highest dose of corticosteroids, even more than rejections. So coming to the recent article, I think the authors have been lucky. The multi-targeted therapies, as such, as we have a proven track record in preventing antibody production in transplant recipient and inducing remission in antibody-mediated diseases, that is in lupus nephritis. While this study is a positive development in primary membranous nephropathy management, I contend that it may not represent the optimal direction, given that there is substantial corticosteroid component in this regimen. You have more than 6 months of corticosteroids, that too of high dose, more than what you use in kidney transplants. And the study design isn't robust. I think the authors concluded as a non-inferiority, but it was not designed as a non-inferiority trial. And also the second part is choosing cyclosporine over tacrolimus, which is actually the preferred CNIs for most indications, raises questions. Furthermore, in the execution stage, you have more than 25% of the patients who were discontinued study medications or were lost to follow, which is actually unacceptable for a clinical entity like membranous nephropathy, which is generally indolent disease, and you don't lose follow-up of patients. And additionally is the duration of follow. They said that they have used mycophenolate 12 months and 12 months. Was it a typing error of 12 weeks and 12 weeks instead of 12 months and 12 months? Because it shows that they have used mycophenolate for 2 years and the reported outcome at 1 year. So the duration of follow-up is something worth considering. Typically, membranous nephropathy, you report outcome at 2 years. First years to assess the clinical outcomes, and the second years for documenting relapses, which is not uncommon, particularly if CNA is employed as one of the treatment arms. Then with respect to PLA2 or antibody also, it's a very confusing part, because the authors have used mean and standard deviation for representing the PLA2 trajectories. Again, that's a limitation. So these are the few limitations that I feel is there with respect to the study. Yes, I don't think, because of the excessive dropouts, I don't think we can have really a generalizability of this study. Yeah, with this, I will stop and we'd like to hear from the other panelists and the chairpersons. Thank you.
Sir, I think we can start with the questions, sir, which the audience have posted. I think the first question was from Dr. Venkatesh Natarajan. Whether there is the loss of 16 patients in the interventional group, will it underestimate the effect?
Perfect. Yes, I think that's what I told. 25% of this patient, of the study population, actually 23% to be precise, were lost to follow-up or discontinued medication. So we really cannot make anything out of the outcome. And
yeah. Yes, sir. Please complete.
The another point that I forgot to mention was the modified Ponticelli performed relatively better than the than the MTT. That's probably also because the modified Ponticelli, the PLA2R was 85, and in the other one it was 200 plus. Although it was not statistically different, but yes, there is a difference between them.
Yeah, that brings to the point, Dr. Raja. I mean, if you can realize it, I mean, there is a difference of more than 150 between the two groups, and still the proteinuria, renal function, everything was similar in between the two groups. So my understanding is how can you have a cohort, I mean, which is actually having a 2 to 3-fold high PLA2R, but rest all are matching. That was again.
I think one point was that there was a supplementary table where they had made a subgroup analysis based upon the Plar tertiles. And in that, it was seen that in both the groups, it was evenly matched. So I think there is probably a typographical error, but I'm not certain, obviously.
It can happen, Dr. Darshan, although it's a good question to think about. But essentially, even patients in various tertiles can have the same degree of proteinuria, creatinine, and serum albumin, but the response will be different. Even the Starman trial, actually, if you see, the PLA2R in the rituximab arm was double than that of the modified Ponticelli. Yes, the other things were similar. Yeah. Good.
The next question was whether there is any follow-up and data regarding relapse after stopping CNI, as CNI was given here for 2 years from Dr. Pallavi.
This is really confusing. Is there any open label extension of the study? I think the authors only probably because they use the medication beyond 1 year. So probably there is something to come, but they have not clarified this in the protocol. I thought there were typographic errors, actually, to be honest with you.
So I think that was another thing, that the drugs were continued for 24 months, but the outcome was only till 12 months. Yeah. And we have a couple of questions about the cumulative dose of steroids, which were used in the multi-target therapy, and a comment that it was very high, and whether the response was because of the steroid dosing rather than the other drugs.
I think very well it could be because of the steroids, because the dose of steroids that they've used is much more than actually kidney transplants. We don't use 1 milligram of corticosteroids even in kidney transplant, and they've used it for a good, nice, time. And after that, also the reduction protocols have been, longish. So I think corticosteroid would have been a big part of immunosuppression with this multi-targeted therapy. Is my take.
Yes, and dose of MMF which they use with cyclosporine is actually quite less. So if you want to use MMF, usually if you in SLE or some other therapy, 2 to 3 grams. So that is what they've used with, if you see with cyclosporine and the other drugs, 2 grams, and this is a 1 gram and even less with cyclosporine. If you are even using with tacrolimus, then it makes sense, but then it's mostly CNI and steroid, and a very high steroid for very long period of time. This impression would be that there would be more side effect in the multi-target therapy. Otherwise, also there are more side effect. And the dose of like in Ponticelli, this what we also use not more than 500 milligram pulse for 3 days. Means 1 gram is the original, but we have never, means 1 gram becomes too high a dose, and I, at least in my practice, I have never used 1 gram pulse for 3 days for that's originally described, because that's too high. And this so I would say that this trial actually does not actually tell about the multi-target therapy as such, which would mean that you use the lower dose of steroid, taper the steroid, and then you use MMF in the higher doses. CNI could be target trough is, we don't know how, when they were able to maintain around 100, or they just based on the because then after some time, 12 months, they reduced to 50 milligram. So whether the target trough level, and an important thing is relapse. Now, after 12 months, they should have stopped and then seen the relapse, that how many of these patients are actually relapsing. That is what we would like to see, that after 12 months. But then they have continued the steroid also for 2 years, which is very actually strange. Yeah.
With regard to the trough level, sir, they had maintained it between 80 to 120. That was what was mentioned.
Yeah, but then the dosing, they also made a fixed dosing 100 milligram, and then they came down to 50 milligram. And
not wrong. Wrong. The levels were about what they had targeted is 80-20, and it was, I think the level they achieved was 68. So it was lower.
68, yeah.
Yes, yes, yes.
And probably
So
they have put it as an advantage for the trial, but they have not explained why didn't they do it.
exactly. So you're supposed to
Yeah,
follow. I don't know why they haven't done that.
One interesting question was from Dr. Niranjan, whether the response has something to do with the race characteristics,
Yeah,
considering that MMF has shown some benefit in IgA nephropathy in Chinese population, whether the same can be extrapolated to Chinese population for membranous.
it'll be very difficult to say because you have 3 drugs and you don't have 1 drug. Like in IgA and other things, you have 2 drugs, lupus 2 drugs, but here it's 3 drugs, and all 3 are used in reasonable doses. But for cyclosporin, which is less, MMF, which is less, but the steroids are large, so it'll be very difficult to make a comment on only mycophenolate mortality. But yes, Chinese responds very well to mycophenolate for most glomerular diseases.
No. I think a comment about the presence of AKI in the multi-target therapy arm, where 3 patients had AKI. So whether we should be apprehensive about having acute kidney injury with the use of CNAs, whether that will increase, especially with significant hypoalbuminemia, which we see in membranous patients.
Indeed, yes. So it's a very small number. It's only 8%.
39. Yeah.
And most of them were reversible, so I don't think it should be an issue. Probably they might have a higher level, and probably it would have come down. So that's my guess, actually. But yes, most of them, all of them were reversible, so it should not be an issue.
Have they given any reason for the dropouts in this multi-target therapy? The 25% patient, they dropped out. So what was the reason of that?
No reason has been given, sir.
Yeah, so that's significant again, as Raja mentioned, but the exact reason is very important. No?
And I think a question was from Dr. Sushma Rani about whether any comment on the combination of Ritux, cyclophosphamide, and steroid. Will it ever come into picture?
It's totally different from what the study is, but there is a protocol which is used in ANCA-associated vasculitis where they use all the 3, and it's from the Harvard University. They've used the same in membranous nephropathy as well, where they give huge dose of rituximab. They give about 8 grams of rituximab. Remember, 8 grams of rituximab, and they used corticosteroids for 6 months, although it's a lower tapering dose, and cyclophosphamide for 2 months. And this regimen is supposed to have 100% immunological remission and 100% complete or partial remission. So that's the study which is published in American Journal of Kidney Disease.
Interesting, sir. I think we have another 2 questions were based on whether it was truly a non-inferiority study, considering that it wasn't very explicitly the non-inferiority margin was not explained and other things.
Yeah, I thought while reading the article, it was an equivalent study, but later the authors concluded it as a non-inferiority. That is what I made in my comment also. So I'm not very clear about it, because you'll have to have a margin, non-inferiority margin. Then you give a dropout rate also. You also factor the dropout rate and then make a sample size calculation. So I think there is a discrepancy between the statistical methods and the conclusion.
One of the things about using multi-target therapy is about the compliance. I mean, you have to have 3 drugs, which you have to take for about 12 months. So one comment about using multi-target therapy, especially oral active multi-target therapy, is the compliance rate definitely will come down. Since this was a trial, probably it is not a real life scenario. And once we start using it in practice, one thing I note would be a drop in compliance. So yes. We spoke about 2 multi-target therapies. One is cyclophosphamide rituximab combination, and the second one is the CNI with thing. There were trials which are coming up in terms of BAF and APRIL inhibitors as another multi-target, inhibiting both APRIL and BAF, not just APRIL, such as the atacicept and the povetacicept. So any comments from the panelists about what do you think? I mean, there are starting trials on membranous. So do you think it would be good to see the results in terms of that? And what do they think about the trial?
I think it's a good question. There is a clear-cut pathophysiology basis for these clinical trials, and it's an antibody-mediated disease. So I think naturally they should work in, at least hypothetically, they should work in membranous nephropathy as well. And it'll be good to see this kind of individualized or personalized medicine in membranous nephropathy as well. Only thing is we'll have to look what is going to be the competitor, whether it's going to be cyclophosphamide and corticosteroids, or is it going to be rituximab, because I think we are all graduating slowly towards rituximab in membranous nephropathy.
Yes, I request the panelists to probably give their opinion about how do they manage membranous nephropathy in their clinical practice. In a nutshell, probably. Your preferred agent, whether it is the modified Ponticelli or Rituximab, for which patients do you prefer what and why?
Dr. Amrish, I think you started.
Yeah, usually for the high risk and the very high risk, cyclophosphamide means modified Ponticelli is preferred. And what I have observed that the remission is good and long lasting. And because I'm working in a government sector, rituximab, because of cost, we are not able to use. So mostly we are using cyclophosphamide and prednisolone as modified Ponticelli because it's cheaper. But what I have seen that the remissions, the side effect profile of both rituximab and cyclophosphamide and modified Ponticelli is similar. There is no advantage about it, and remission is maintained better with the modified Ponticelli. So it's my personal opinion. But however, according to the guidelines, in moderate risk, we should rituximab should be the first agent for therapy. But for poor patients, the cost also matters. Well, so Dr. Raja will be in a better position to tell, I think.
Thank you, Dr. Amrish. So yes, with respect to our practice, previously we were using only, like I will tell you what I've been doing over the last 12 years. So we were only using cyclophosphamide and corticosteroids in the cyclical patient, and we use that 1 gram dose. So it's about 13.5 grams of methylprednisolone equivalent. So that is what I was using. Then when rituximab came, what we did was for patients who were affordable, who were young, who were not ready to take cyclophosphamide and corticosteroids, or diabetic, we used to give rituximab therapy. We initially started with the CD19 targeted therapy. Now we then graduated slowly to 1 gram on day 0, day 15, and day 90. And after that, then we moved on to using cyclophosphamide and corticosteroids in patients with high titers of antibody and rituximab in low titers of antibody. And now actually what we do is, give rituximab as a first line therapy, and corticosteroids and cyclophosphamide in those patients who have very, very high levels of anti-PLA2R, like 1000 plus, or in those who have kidney dysfunction. Because, rapidness is very important, and cyclophosphamide and corticosteroids, the rapidity of achieving remission is better vis-a-vis the rituximab, which takes about 9 to 12 months to achieve remission. So that's how I look at. With respect to rituximab, what I have learned over time is like, giving the first dose is not the important one, but, giving in between 3rd to 6 months is going to be the key. Because many a times you will see that antibody do come down in the first 3 months, and there will be a resurgence. So you will have to actually see off that time also with an additional or a top up or booster, whatever you call, dose of rituximab therapies. That's how I see it.
Dr. Raja, may I ask about the risk of infertility, which people are so afraid with cyclophosphamide? I have seen patients getting pregnant while on cyclophosphamide, though we advise against pregnancy. So do you think that the infertility thing with cyclophosphamide is so significant as people believe?
Yeah. So if you have to look at the data, so membranous nephropathy is disease of middle-aged, where the number of ovum would go down. Like generally it's 35 plus. In the Western, it's 45 plus, and in India, it's 35 plus. So usually there, the ovarian reserve is poor. So with respect to the dose of cyclophosphamide that we use, for a 60 kg man, we use about 13.5 grams of cyclophosphamide in the modified Ponticelli protocol. So if somebody is more than 30 to 40 years of age, so usually, by 9 grams, usually they say that most of them would become infertile. So one odd patient not retaining fertility would be a different thing, but most of the patients would achieve amenorrhea with this dose of cyclophosphamide. Yes, sometimes we use lower dose of cyclophosphamide that may not result in amenorrhea, but the standard dose that we use would result in amenorrhea in somebody who is 35 plus years of age. The lower age group, you may not have that effect. With respect to the males, you don't have this kind of an impact. So it's actually, if you use 13.5 grams, you got a probability, if there is a 75 kg man and you use a 13.5 grams of cyclophosphamide, there will be a 30 to 40% chance of azoospermia, which is lower in male vis-a-vis in a female. Because the reserves go down and ovarian reserves goes down with age. So that's the reason.
Okay. Do you, once you have completed the course of rituximab and you are following up with APLA2R titers, and patient is in partial remission, he's doing well, he's not, his serum albumin is more than 3. So do we still give intermittent doses just based on the rising titers of APLA2R? That was one question, Dr. Raja. And the second thing, what I want to ask is, how differently are you managing patients with NEL1 now that NEL1 is being regularly being done across centers, and we have identified that there is a small chunk of patients who are APLA2R negative but NEL positive. Are you still using rituximab for this cohort? And if you're using rituximab for this cohort also, we can't monitor serum markers in them. So how do you give boosters of rituximab in them?
Yeah, I think both the questions are very important ones, and I will take one by one. The first question would be is you monitor PLA2R, and if there is a resurgence of PLA2R, do you treat it? The question is, after the first 6 months, that is after you've given the first 2 shots and the booster shots, and you monitor PLA2R every 6 monthly. So if the antibody is going up and if the patient is not nephrotic, we essentially don't treat, because membranous nephropathy, you essentially don't proactively treat if the patient is not nephrotic, because there's a small chance that 1 in 5 patients would go into spontaneous remission with low titers of antibody. Low titers means less than 100, not the 20 or 30. So that is with respect to question number 1. With respect to question number 2 is about NEL1 and membranous nephropathy. I think one thing that we need to be mindful of is use of complementary medicine and NEL1 membranous nephropathy. Malignancy is a less encountered situation in the Indian population. We just published our multicentric report of more than 10 centers and L1 membranous nephropathy, and what we found was there was no malignancy reported, but more than 50% of the patients had use of complementary medicine. I would actually say that even in our unit, we actually went back and asked these patients after L1 was actually diagnosed. That was the time they actually confirmed that yes, they were taking complementary medicine. And 50% of the NEL1 membranous nephropathy would actually respond when you stop the medication or the facial cream or the fairness cream. They would respond. Only in 50% you will actually require treatment. With respect to treatment, we have treated them with cyclophosphamide and corticosteroid and rituximab. I think the response rate in both of them is 80+. With respect to how do you monitor them, it is just like non-PLA2R membranous nephropathy. You essentially go by, if at the end of 3rd month, if the patients have not achieved, partial remission, you would give a top-up dose. So that is how you would go about. That's how I go about, because there is no protocol for non-PLA2R membranous nephropathy in rituximab use. This is what I follow. So if you give a 3rd dose if the patient have not achieved a partial remission. But yes, looking at the complementary medicine is an important factor.
I think 2 final questions we can take from the audience. One was whether DAPA is a routine standard of care in the supportive therapy before we start immunosuppression, along with ACRs now for all the finalists. Dapagliflozin SGLT2 inhibitors. I
think DAPA is mainly focused on IgA nephropathy. There is no significant role in podocytopathies and membranous nephropathy. Yeah, may have a role in reducing proteinuria, but like in all antibody-mediated disease, like MCD, membranous nephropathy, they're all antibody-mediated disease. I think you can hit them right. You can hit them with a stick, so you need not have to take all these steps.
How about the others, Dr. Amresh sir and Dr. Sham sir, Dr. Darshan sir? Do you all use DAPA?
Yeah. See, I use now because there's a more and more evidence that you can use dapagliflozin in most of the proteinuria kidney disease, especially if you are not over nephrotic syndrome, serum albumin is not very low, and after your partial remission or something. So you are starting at therapy, obviously you will observe for 3 to 6 months, and the patient is not having severe hypoalbuminemia, no urgent indication to start And if he can tolerate, I will start DAPA in now most of the patient, even with all top types of glomerular diseases. And once if the patient is not responding with any of these, then obviously you have to go for the immunosuppressive treatment.
Sir, I believe that in conditions where we have a chance of remission, it is better to wait rather than to use DAPA right at the outset. So, for example, if membranous GN, if we are planning to use any immunosuppressive drugs and there is a good chance of remission, so if remission is achieved, then I don't think that DAPA will benefit. And especially when we are using DAPA in hypoalbuminic patients with ACE inhibitors, the chances of acute kidney injury is also there. I have seen people who are using DAPA even in, say, MCD and FSG. So I think that we should wait if remission can be achieved in these conditions. And if remission is not achieved, then we can use it as an add-on therapy to control the proteinuria, similar to what we are using for statins.
Yeah, no, see, you have to choose your patient. That is very important. If somebody has edema, somebody has reasonable blood pressure, and then if you add on gradually, that is the, you will not obviously patient who are hypovolumic or the patient who has impaired renal function, you will not start. And then the second group of the patient is once those patients achieve partial remission, but still has substantial proteinuria or some proteinuria. So in those type of the patient, obviously DAPA would be useful. So you have always to see and monitor these patients, whether they are developing any sort of hypotension, they are developing AKI, and so not all patients are same. So it's not for everyone, but then you can it substantially reduces proteinuria in most patients with glomerular disease. Obviously, in minimal chain disease, you will not use dapagliflozin. Patient with FSGS with the severe nephrotic syndrome, you will not use dapagliflozin initially, but later on, once there is a stabilization or there is some proteinuria and hypertension, you will use dapagliflozin in these patients.
Certainly, sir, point.
The drug of choice for a patient who does not respond to modified Monticelli, would you prefer Ritux or CNA? From Dr. Sandeep.
CNI is in membranous nephropathy. I think you reported even the 6-year outcome. So it's like kicking the can down the road. So you may whatever you achieve today is going to be lost tomorrow. It's like so that's how I look at CNI. With respect to somebody who is resistant to cyclophosphamide and corticosteroids at 9 to 12 months, then what you do, you could add a rituximab as the therapy in them. So I think that will be the best way to do. Even the KDIGO writes on those lines.
Yes.
Okay, so I think I have taken most of the questions from the audience, and it is already 9. So I'd like to thank Dr. Paramita for a very detailed and a visual appealing presentation. Our esteemed panelists, Dr. Raja Ramachandran sir and Dr. Amresh Krishna sir, thank you. Thanks a lot for being here, and Dr. Bansal sir and Dr. Darshan sir as always. Thank you, and thanks for all the audience. We'll be catching up with you next month on the 3rd Wednesday as always with another round of. Thank you.
We'll also be sharing the link for the today's presentation and the previous recorded presentation. So kindly, if people who have missed out, kindly log in and you can watch the presentation for all the last 1 year journal clubs. Yeah.
Thank you both of you for providing the opportunity. And Dr. Bansal, thank you so much.
Thank you, Raja, for your nice.
Thank you, sir. Thank you. Thanks a lot.